Well, welcome everyone. I think we'll go ahead and get started. My name is Tim McKee. I'm the CEO of the Olathe Chamber of Commerce, and I'd like to welcome you to our first business lunch series for 2021. I think we have a really good one. But before we go ahead and get started, I'd like to thank some of our sponsors for our business lunch series, and those sponsors are Humana, Johnson County Community College, John Deere, and Nabholz. So we'd like to thank those sponsors of our business lunch series, and we really appreciate all their help and assistance. Before I introduce our speakers today, I'd also like to introduce Sarah Meismer. Sarah Meismer is with our team here at the Olathe Chamber, and she's going to help me monitor the chat and the questions and answers. And hopefully, as we go on, we'll have some time at the end to take any questions or chats that we received from our people viewing today. So please feel free to send those over, and we'll try and monitor it. And hopefully, as I said, we'll get to it at the end. So today, our business lunch series, we are going to have an update on the COVID vaccination and where we are in that process right now. And we've got two great people to speak to that. And I'm going to introduce them here briefly and then allow them to kind of give us a 2-minute update, and then we'll go right into some questions and answers. So our first speaker is Dr. Lee Norman. He is the Secretary of the Kansas Department of Health and Environment, which is KDHE. He has 2 master's degrees, one in health planning and systems analysis from the University of California, Davis School of Medicine, and an executive MBA degree from the University of Washington Graduate School of Business. After serving in the United States Air Force as a family physician, flight surgeon, and combat medicine instructor, he practiced medicine in Seattle for over 20 years. Dr. Norman has served as Chief Medical Officer for over 26 years, most recently at the University of Kansas Health System, and before that at the Swedish Health System in Seattle, beginning in 1991. He currently is a clinical assistant professor at the University of Kansas School of Medicine. So Dr. Norman, thank you for joining us. Our second speaker is Dr. Sammy Ariola. Dr. Ariola is the director of the Johnson County Department of Health and Environment. Before serving in that role, he was Deputy Director of Health for the Metro Public Health Department in Nashville. He served in multiple capacities in his 17 years in Nashville, including as Director of Bureau of Environmental and Health. Dr. Ariola has a bachelor's in agriculture, animal science, and his doctorate in environmental toxicology from Texas Southern University in Houston. So thank you, Dr. Ariola, for joining us as well. So with that, I would like to turn it, I think we've talked about this, and Dr. Norman is going to go first, and then we'll turn it over to Dr. Ariola. So Dr. Norman.
Great, thank you very much. I appreciate it a lot, Tim, and thank you for the invitation to speak. And besides that, it's so great to see my dear friend, Sammy Ariola. We mostly talk on the phone or trade emails, and we never see each other's faces. So valuable colleague and happy to be here. The overall, that I think we're doing pretty well in Kansas. I mean, for as difficult as this has been, and you know, for the last year, it's all been a study of shortages. It was shortages, if you remember, on PPE and testing platforms, testing equipment, case investigators, and therapeutics, and now it's the same thing going on with vaccine. And it's been hard for everybody, us at the state. I'm sure Dr. Ariola and colleagues throughout the state and the various counties are feeling the same thing, which was there's a terrific demand for vaccine, and it's been hard to keep up with the demand, needless to say, because the supply has been erratic and not quite enough. That being said, Kansas is doing pretty well in terms of the number of cases, and we're, where we were seeing statewide 1,000 to 2,000 cases a day, and dozens of deaths per day. We've been having and really it started in about November. We had a little bit of an uptick, and then the number of new case development the trend line has been positive. Hospitals that used to be just full of patients are now have very few COVID-19 patients. And this is true whether you're small, medium, or large hospitals. There were lots of staff shortages because people were in isolation, quarantine, ill from COVID-19, and that's much improved. So I think that on all things considered, things are improving. The statewide, the percent of testing, and by the way, we've had a very aggressive testing throughout the state. 2.9% of the tests are positive for COVID. We remember when it was not that many months ago when it was 16, 18% test positivity rate throughout the state. So the trend lines are going the right direction. Vaccine has been a challenge. We now have, as you know, 3 that are approved. We've received slightly over 1 million doses into the state of Kansas. We've have administered statewide about 750,000 doses, about 745,000. So about 73% of the doses so far, according to the publicly available databases, have gone into people's arms. Now, one of the things that we do know, and I know that Stan Holm, he might be on this call, a terrifically valuable president, CEO of Olathe Med, and a great advisor to me personally. I get together with our hospital leaders, again, small, medium, and large, and Stan has been a terrific thinker about this stuff, been very effective at getting product into people. There's been no shortage of difficulty, though, in getting data into the system, and I do know that there's been struggles, and so Kansas has been kind of beat up, and I personally have been rather beat up as being a bottom dweller, when in reality, the amount of vaccine getting into people's body is much higher than what is reflected in the databases. Watch for the next 10 days, and you're going to see a change in the publicly available information at the CDC. The last comments, and I'll hold anything further for now anyway, is that it's very controversial about the phases 1, 2, 3, 4, 5 in the state of Kansas. CDC numbering, Missouri's numbering is a little different. We're in phase 2, which will be the largest phase with the most people. People have there's a difference of opinion, if you will, that of vaccinating a population. For example, childcare workers, teachers, food workers, factory workers, long-term care. That focuses very much on a population of people, not only to vaccinate those people, but to prevent spread from population to population. We've gotten a lot of people, and it's caused a lot of irritation in people that in phase 3 are people below the age of 65 that have medical conditions. How come they're not higher up on the list? So it's this and we follow the CDC guidelines in the state, but there's this continuous push and pull between how do you treat a population and how do you treat an individual, collectivism versus individualism. And that's a tough one, because anybody you pull up into phase 2 bumps somebody else out of phase 2 into a lower phase. So it's a zero-sum game when it comes to a fixed amount. We've gotten all the doses in the state of Kansas that we're supposed to get. None of it has slipped through our fingers. It's allocated on a per capita basis. That's why we've been somewhat protective, as you know, of vaccinating people who either live and or work in Kansas, not wanting to necessarily vaccinate people from other states because we aren't allocated vaccines sufficient for people from other states. And that has caused a little bit of a heartburn in some individuals. So I guess in summary, my hat's off to all of our counties. Some are pulling, and we have about 5 or 6 or 7 that are the very large ones. Dr. Ariola, of course, is with one of those and has been a terrific colleague through all this. We've had to invent things as we've gone. There has not been a playbook for a pandemic of this nature. And with what I would say was throughout this not great cohesive federal public policy to guide us, it left us into a situation of competing with other states and even FEMA. I think we've come through the other end of it. I think there's a light at the end of the tunnel, and I'm really pleased to have the opportunity to answer questions when it comes to that, Tim. Over.
Thank you, Dr. Norman. Dr. Ariola, would you like to go ahead?
Yes, and I'll start off also by acknowledging the terrific cooperation that we have had with Dr. Norman. I really moved here just in a few days. It will be a year since I got here, and one of the first people I reached out to was Dr. Norman. Like, hey, I'm new here. When I accepted the job, I wasn't thinking I spent the first year dealing with the pandemic, but his support has been great. And we, of course, people see what we talk about openly, but there's a lot of collaboration behind the scene, and lots of collaboration from him that I want to acknowledge. In terms of the response in Johnson County, one thing that we have done from the start is ensure that we are distributing the vaccines as soon as we receive them. Every shipment that we receive, we have given them out within days of receiving them. And I've had to answer the question from people thinking that we are hoarding vaccine. We're not. And Dr. Norman mentioned Stand Home with Olathe Health. Our approach from the beginning was not to create any bottleneck, thinking that every vaccine has to go through the Department of Health and Environment. We always thought that 20, 30, 40 providers are a lot better than 1, 2, or 3 clinics. And that's consistent with what Dr. Norman at the state has done. That's consistent with what they have done at the national level. And so we started working very early on with our health systems, Olathe Health, Advent Health, KU Med, St. Luke's, Menora, and Overland Park Regional. And I think that's paying off. We were not just setting ourselves up for when we were getting 2,000-3,000 doses a week. We were setting ourselves up for when we're getting 20,000, 30,000 doses. And everyone has the capacity to even push further. The problem for us is not the capacity to distribute. It is supply, like Dr. Norman said. And that's the way that this has been built up. We started up early on, establishing relationships with our other partners, our pharmacy group, and they've been very helpful. After the Federal Pharmacy Partnership Program, which is the program that vaccinated in our long-term care facilities, there were a few independent living, other senior facilities that were not part of that program. And that earlier relationship with Hy-Vee, with Walmart, with Urban Pharmacy is what we have used to vaccinate the 27 facilities that were not covered there. It is those relationships that's allowing us to vaccinate our homeless population, which we started last week and vaccinated 62 persons at Project 1020. It is the relationship that we are harnessing and using with Olathe Health, Stand Home and his group to vaccinate on the 11th, tomorrow, as well as Saturday at Salvation Army. It is the same relationship that we are using to take vaccine to our residents who are homebound. As a matter of fact, five minutes before I called in, our staff were just heading out for the first vaccinations. So they plan to do 20 today and 30 tomorrow. And it's the same relationship that we used to work with our transit authority to be able to move our residents who need help to get to our vaccination clinics to bring them to vaccination. It is, again, same relationship for our intellectual and developmentally disabled residents. That's about 2,000 of them, working not just with the Johnson County Developmental Services, but also other stakeholders in the IDT community to get a third-party pharmacy to vaccinate them. That was, we gave them the vaccine last week. That's ongoing this week. And the reason that I went through all of that is because still the primary lens for us at which we look at this is equity. We want to get vaccine into the arms of as many people as possible. The focus on our older population, the focus on our more vulnerable population reflect the same thing. And now we're working with some of our health systems, including Advent Health, in reaching out to our minority population. And focusing on taking vaccines to people at their churches and to the people that they trust in the community. And it's the same thing that we're using in the next 1 to 2 weeks, trying to finish vaccination of our grocery store workers, as well as our restaurants and bar workers. We just finalized plans to vaccinate in our corrections facilities. All of those are going to happen in the next few days to 1 week. So, and that's still maintaining focus on our 65 plus. I think we're going to have some work to do there because we have focused heavily on them. I think we've vaccinated close to 50% of our population there. We do have over 95,000 of our residents that are 65 plus. And I think we're getting to a place where our appointments are not being completely taken up. And that's also true for that's the same thing that our health systems are seeing. So we might be getting to a place where we have to educate more. We're also using organizations with relationships with this organization, the Area Agency on Aging, to call people and book appointments for them. So we're going to have to continue to be creative as we go through this. But we're getting more doses from the state. And I don't want to use the word hound, but I've been hounding Dr. Norman, and he has responded. I'm very, very grateful for the collaboration. We're getting more doses into the county that we feel pretty good where we are in the next few weeks to be able to not just vaccinate these somewhat smaller groups in phase 2, but continue to get deeper into vaccinating in our 65 plus. And up until now, he did talk about data. I would tell you that we have at least one health system here who has not been able to enter over 17,000 data into the system. And so the data is lagging. There's no question about that. And so for me, my estimate is we are very close to having vaccinated close to 15% of our population, at least the first dose. Now, what you see online will be more around 12%. But when all of the data are entered, I think that's closer to that. And I think by the time we finish all of our clinics this week, we had 5,600 appointments booked for 65 plus this week. And there are appointments also that's going to be announced for next week. So we're chipping away. We really are. We are vaccinating the vulnerable population. Our numbers are encouraging. Again, I do put the caveats there that our testing is not quite as up to where we want it. But I also acknowledge what Dr. Norman said, the infusion of several testing resources into counties. In December, we were able to create appointments of about 1,800 testing spots weekly in the county, but the state came up and added over 3,000 testing resources. And those were very good because if you test, you know your status, you take the right procedure of isolation, and so you are not unknowingly spreading the virus. I think those are the reasons why we are seeing the drop in numbers. The last time I checked, this morning, we are about 3.2% positivity rate. With our incidence rate number dropping significantly. So we haven't seen those kind of numbers in a long time. And one of our initial focus, it was we wanted to keep our childcare establishment open. We wanted to keep our schools open. That's been very consistent in the past 1 year for us. So we started allocating a lot more resources to vaccinating our teachers and childcare establishment, even before the governor and Dr. Norman pushed resources to the city. So it allowed us to finish vaccination very quickly. So the last of those that are interested in getting the vaccine in our K through 12 educators and childcare establishment yesterday were vaccinated yesterday. Okay. And so out of 15,700 staff in our public schools, we have vaccinated 13,334. 85% of them have received their first dose. The second dose will finish the first week of April. Now, out of our private parochial schools, we have vaccinated 97%. Out of 1,165, we vaccinated 1,160. Our childcare establishment, we have vaccinated greater than 65%. Out of the estimated 3,809 staff, we have vaccinated 2,484. So again, we emphasize that the reason why these groups are very important is the reason why you and I are able to go to work and keep our economy going is because we can take our children to childcare establishment, is because they can be in school. And that's why 2 weeks ago, I wrote a letter to our school superintendents supporting their efforts for in-person school, because not only have we vaccinated very strongly there, we have infused resources into the school. At some point, we had about 20 workers that we hired on a part-time basis that's working with our schools to do contact tracing, case investigation. We infuse a lot of resources into testing. We meet with them, the superintendents, weekly, and talk to the school nurses on a daily basis. We hired new epidemiologists, and we attached one epidemiologist to every school district. So we were working very closely with them to implement our non-pharmaceutical interventions, everything geared towards keeping our schools open. So pretty happy that we've been able to do that, kept our childcare establishment open throughout, never closed them down for the same reasons, because we are pretty aggressive and very intentional in our efforts to keep them open. So that's a lot in a short time. Happy to take questions. But again, Dr. Norman, I'm glad I'm here with you.
Thank you, Sammy. Me too.
Yeah, well, thank you both for being here. So you've answered a lot of the questions that I had in the beginning, but one of the things we talked about, and Dr. Norman, you both spoke to it, is just kind of some of the local trends. And Dr. Ariel, I know that one of the benchmark, you had certain guidelines or benchmarks that you wanted to see the county within. And I know one of those benchmarks was the positivity rate being below, I believe, 5%. Now we are at 3.5%. So I think we're now in the green versus red. Can you talk, Dr. Norman had talked about that. And actually, I'd like to get to Dr. Norman to talk about the rest of the state as well, too. But Dr. Ariel, can you dive in a little deeper in regard to the trends and what we're seeing here in the county? Because I know they are dropping, which is a wonderful thing for all of us.
Yeah, I am happy to. I think we like to know that the numbers that we are seeing are because we work together as a local public health system. Back in October, November, when those numbers were really going up very rapidly, we really talked to elected officials. We elicited the cooperation and support of our health systems, and several of them made appeals, had several programs appealing to our residents to just continue what we have been talking about, wearing masks, physically distancing, and all of those, and also cautioning people what might happen if we abandon those things during the holidays, from Thanksgiving to the Christmas holidays. And you saw we had some of our highest testing numbers in December, which indicated to us that people were listening and people were being very careful. People sacrificed, and we're seeing those numbers. So yes, our target then was 5%. It's been one of the targets that the World Health Organization had set very early on, that positivity rate is below 5%. That's a good thing. Towards the end of last year, we were a little bit jealous of places that had numbers below 5%. For us, we were at some point over 20%. It's like, okay, are we going to lose control of this virus or not? So, but it's even with the caution that we have in terms of the decrease in the number of testing, even with the concerns that we continue to have that the trajectory might change if we don't continue along the same path with the concern about the variants and those things. I think it's important to give credit to our residents for just their cooperation and understanding that we have to do this collectively. Now, we were one of the first jurisdictions to put some of these metrics together for our schools. So what we call the gating criteria. And of course, when we put it together, we did not think we were going to be getting 600 cases a day, which we did. So those were really scary numbers, not just positivity rate, but the incidence rate. But then I look at the numbers recently, is very encouraging. Our numbers, again, are down, signifying at least some measure of lower community spread. What's more impactful to me in terms of decision making is that those numbers are associated with reduced hospitalization. We see that in our hospital metrics. And it's the reduction in death. And just you can just track the trend. And that, again, just tells you the decision to focus on our residents in long-term care facilities, the decision to start vaccination in the older, more vulnerable population is just a testament to decisions that are made based on the data that we have. And that's been very, very impactful. In November, we had outbreaks in 49 long-term care facilities. The last time I checked on Monday, that number was down to 1. And that 1 was about 4 days removed from being out because we require 2 incubation periods or 28 days before we let them off. That's huge. That's huge, from 49 to 1, almost 0. Now, does it mean that there won't be other outbreaks because people are constantly coming in that have not been vaccinated? No, there will be, but it's easier to deal with than when we had 49 on the list. And so those numbers are down. It's, again, the reason why we are able to support our schools. We know it's a risk. We know in-person right now means less opportunity to do physical distancing. But we just feel like with those vaccination and their efforts, the schools have been very diligent, and the resources that we have in place, that hopefully there are risks that we can manage.
Dr. Norman, any additional information you'd like to add on the state? What I found interesting too early on is that some of our hospitals were getting overwhelmed, and I know in rural areas it's a problem, because of just the access to medical care. Has that been addressed, and are we seeing some of those issues around the state, which I know that impacts the number of vaccines and where they go as well too, because you want to help those populations that are vulnerable. Has that trend changed, and are we seeing an uptake throughout the state?
Yeah, that's actually a few really good questions that are kind of tied together. Let me first say the original question was about rural and how does that compare? And as you know, Kansas is a very diverse state in terms of urban, kind of middle-sized communities, rural, and frontier. And from the very beginning, we knew that there was not going to be one size fits all. And I'll also just say straight up, Kansans are very individualistic and kind of, I won't say hard-headed, but kind of don't like being told what to do, and rather to do a lot of local customization, which I think I support also. It's been a strength and a weakness because, and Dr. Ariola talked about masks and social distancing and the like. We early on did not see much disease at all in rural communities, and it kind of lulled our rural counties into complacency a little bit and to discount the importance of masks and the other anti-infectious measures. The chickens eventually came home to roost, and they came home to roost in a very bad way. And it was with 30-40% test positivity rates. And I remember, I don't know if you know this, I'm a colonel in the United States Army as well, the Army State Surgeon of Kansas, and that's what I do in my spare time. I've been in the military for 20 years now. And I remember one weekend having a Black Hawk helicopter aerovac a bunch of ventilators to one of the communities out in far west and southwest Kansas. So not only did we eventually did we have to get help the rural counties to kind of come up to speed, because it eventually became a lot of cases, deaths, hospitalizations, and overflowing the hospitals. But it was also that the meatpacking industry was severely hit, which also gets to racial and ethnic, kind of the diversity, equity, and inclusion considerations. So we've always had the meatpacking industry on our radar for very aggressive testing, and then now with vaccinations. Sammy pointed out about teachers and childcare workers and the like. That's a big industry sector. A third of all the beef in the United States comes through Kansas. And so not only for the health of those individuals and their families, but for the commerce and for food supply and industry to remain healthy, they've always been a focus. And I think have done very well as a result. We'll finish the meatpacking industry, at least the first vaccination, this week or early next week. We have about 60 meat processing plants in Kansas, and big industry sector. And you've heard Dr. Ariola and I talk. We both are, and I'm not speaking for Dr. Ariola, but the first dose is all important because you get these are such good vaccines. And you really significant immunity from even the first dose. Obviously, with the the Pfizer and the Moderna, we want to make sure people get 2 doses, although there's a discussion of changing that. It's still in place for now. But, it's interesting, and Tim, you brought this up, the uptake of it, people have beliefs. Some people will never get a vaccine or the vaccine. Some people are kind of taking a wait and see attitude, and some just sign up. They come in with their sleeves rolled up and say, I don't care what you shoot me with, just give me a vaccine. So it's been fascinating going multiple languages to have education and promotional materials available in many different languages. So overall, I think we've tried to balance how do you move through the various phases in rural versus more urban Kansas. We have probably eight counties, I think, that are done with phase 2. So we've put, and here's the public perception. They've asked to be put on pause and not receive allocations so that we can bring along the other counties, the more populous counties. So Doc Norman has been accused of punishing people who are efficient, and that couldn't be further from the truth. What it is that these phases are based on people's risk, the risk of illness, death, but also the risk of significant societal impact from a infrastructure perspective. I mean, we work with Homeland Security. I guarantee you, when I put wastewater workers and drinking water workers into phase 2 as essential workers, I caught all sorts of flack. And I guarantee you go down to Texas, people have a whole new appreciation for water. When they flush their toilet, they want it to go somewhere. And when they turn on their spigot, they want to have fresh water coming out. Those are the kinds of balancing acts that we do. It's never easy. But back to the phases, it'll be really good to then put some on pause and then bring the other more populous counties that need a little more time to get through that. We will not get, and I don't know, Sammy and I haven't talked about this, but we will. We won't get all of a sudden a point in time where we say, okay, boom, we're done with phase 2. Now we can move on to phase 3. Because to do that, that would stop the whole flow of the boost and prime and boost doses. At some point, will be an overlap where we start saying, yeah, you're pretty well there. You all out there, you there can go ahead and start moving to phase 3. We haven't reached that yet, but I think it's going to be sooner than what we originally, and you've intimated this, Dr. Ariola, I think it's going to be sooner than we had originally talked about, just because demand of vaccine is always uncertain, and we don't want to have a pause where then all of a sudden things stack up into inventory. We want to get it into people's arms.
Sure. And Dr. Norman, Dr. Ariola, and either one of you can take this. Where are we exactly in regard to the percentage of Johnson County residents and then the state residents with the vaccine? Can you talk a little bit more about the different phases? Because I think a lot of people are, and I know there's a lot to each phase, but can you talk a little bit about the different phases and then where we are in those phases? Because I think a lot of people are like, where do I fall? And, and where are we? Are we in phase 2 or phase 3? And do I fall in phase 2 or phase 3? And maybe that's too big of a question, but can you talk a little bit about some of that and just the percentage of Johnson County residents that have it in state, and then talk a little bit about the different phases? And either one of you can take that first.
I'll start and let Dr. Norman then expand that to the state. I think he started also by talking about the differences between the rural parts of the state as well as the more urban part. For example, in phase 1, dealing with healthcare workers, we had over 25,000 people registered as healthcare workers. We're still vaccinating healthcare workers. Again, to his second point of there's going to be overlap between the phases. So it's not just the population, it's the fact that we have a larger concentration of healthcare workers in Johnson County. For us, in phase 2, we have our residents that are 65 plus are over 95,000. As you saw in our schools, it's total and childcare establishment, that's over 20,000. So if you put that together in phase two, our estimate was that we had anywhere from 120,000 persons to 150,000 growth. That's a fourth of our population, and perhaps more than a third of those that are eligible to get the vaccine. And so that's a huge group. And I think that's what he said. And that phase two is huge. And number one is what I say. And that's Dr. Norman has sent that your way. When people ask me, I tell them I have zero control over what's in phase two or phase three. If they have issues, they should call you. However, what we're able to do is prioritize within the phases. I will say that you can make a case for why some groups are in phase two or phase three. What's also true is if you keep loading phase two up, it just means we are going to be there for a long period of time. And we're all hoping that we get to a point where if you want the vaccine, you get it. But we're not there yet because of supply issue. And so you've got to do it somehow, some way. And the reasons behind that to protect the vulnerable, to protect critical infrastructure, I think those are understandable, no question about that. Now in Johnson County, like I said earlier, what you're going to see on our public-facing dashboard does not really reflect where we are because of lags in data. I am personally aware of two institutions with thousands of cases that have not been able to be uploaded. They're working with KDHE to get those in the system. And so my estimate is definitely by the end of this week that we would have vaccinated over 15,000 of our residents, 15% of our residents, I'm sorry. Right now we have done over 110,000 in terms of total doses first and second. And so that's good. And if we're getting the same doses that somebody asked me that question yesterday, we're getting what we're getting right now weekly. Really, by the time we get to the end of March, definitely end of April, we're talking about vaccinating a huge portion of our population. And that's not talking about some that might already have natural immunity if they are infected and all of those details. So the numbers are going to be better. They're going to reflect what the true situation is. The other point I always tell people is all of the doses that we get between us, the Department of Health and Environment, and our partners, we give them out the same week. We also have been very clear working with our partners on ensuring that we have the ability to enhance our capacity. That's why, again, if we get two to three times what we're currently getting weekly, I think we feel pretty comfortable that we're able to still dispense all of those within the week that we receive them. We don't hold on to them. As a matter of fact, if I did not get the vaccine shipment that came in yesterday was Tuesday, we would not have been able to run our clinic today. So we had 1,400 spots yesterday. We had less than 1,400 doses available to us yesterday. So that's how quickly we give those out. And I know, again, there's some of our health systems that are listening. There's been times when every week our health system are saying, can we get this more? We have this many appointments. I can't really meet that because we don't have the doses. Our partners are ready to go. When we get but my point is, if you want the vaccine, we're just asking that you be a little bit patient. We're working through our list, doing our best. We're all working towards the same goal. You want the vaccine, I want to give you the vaccine. So really, it's just more about timing and some logistical things, but we're all on the same page. And at the end of this week, I think we would easily have given at least 15% of our population the first dose.
Dr. Norman, where are we, from a state perspective? And then how do we compare with some of the other states? That's a question that we get all the time as well, too.
Yeah. We don't appear to be as good as the rest of the state because of the data problem that Dr. Ariola mentioned. We but we are good. We are getting vaccine into people. We have very low inventory. We have one problem county. It's not Johnson County. That needs some help that they've not been able to keep up. And part of it was due to that week that it was so cold and icy and snowy that we didn't get any vaccine that week because they weren't flying out of Kalamazoo or out of Memphis with FedEx and that kind of thing. We just did. And then the next week it was like raining vaccine on us. So some people just haven't caught up from that. But we're doing well. It doesn't necessarily look that way in the rankings, but I'll tell you, in about 10 days, look again, and it's going to be a lot better because we're fixing the interfaces that Dr. Ariola has mentioned. We are about the same. I think we're right at 16% of Kansans have received at least their first dose. I think it's now 10% of Kansans have received both doses. And as pointed out, the number of vaccine coming into the state was much lower. And especially starting after the 23rd of March, it's going to be a much more vaccine coming into the state. We can handle with our current number of vaccinating sites probably 5 to 10 times the amount of vaccine that we're now bringing in. We have a lot of vaccinating sites that we haven't even activated yet, just because why turn them on and have people calling and when they don't have any vaccine. So we try to consolidate it with the higher vaccinating sites. But Dr. Ariola described, by the way, and I think it's really important, the secret sauce in a county is the cooperation between the local health departments, perhaps hospitals, federally qualified health systems or health centers, pharmacies, and the like. There's counties, we have 105 counties in Kansas, and there's some where they do not have longstanding favorable relationships with each other. But fortunately for the populated county of Johnson, great relationships, and that's the secret sauce. I do want to address the question you brought up, Tim, about prioritization. Why are some things in phase 2 and why are some in phase 3? And let me start off by saying we started with CDC in October. In mid to late October, we submitted our prioritization plan to the CDC because if we have a contract with the CDC to distribute in certain ways, and it's based on our prioritization plan that we developed. This was not some kind of made up, pulled from the air numbers. We worked with the CDC, the Advisory Committee on Immunization Practices, and the Department of Homeland Security to say what are the best, what people are at the highest risk that are because of their age. And by the way, age is one of the most important risks. Dr. Ariola mentioned that already. 85% of Kansans who have died of COVID are over the age of 65. Below 65, it drops off quite dramatically. Like I said, only 15% below that. So it's based on how able is somebody to isolate and quarantine. Do they have to go to work on a bus? Can they separate? For example, a preschool teacher, there's no way a preschool teacher can keep from getting sneezed on and mopping noses and that kind of thing. But a college professor, and I saw one of the questions in the chat box, is why aren't college professors in phase 2? Why are they in phase 3? My answer to that is some are, by the way, in phase 2. Those are the ones that teach physical therapy, that are direct hands-on. They're teaching medicine, nursing, dentistry, and those kind of things where social distancing is absolutely not possible. So they are in phase 2. But those that can physically distance or remotely learn are not in phase 2. They're in a lower down phase. But these are based on risk. They're not based on a popularity contest. They are based on what's the risk that a person can avoid getting ill and or if they get the illness that they'll require hospitalization and death. And as Dr. Ariola pointed out, phase 1 was also about healthcare people. Not only cannot they social distance, but they also, we didn't want hospitals to get overrun and not have staff to take care of people in hospitals. And I use healthcare rather broadly. There are some first responders that are healthcare and the like. I feel uneasy at times because there's brains out there like Dr. Ariola and his colleagues around the state. And I think we sometimes do constrain them a little bit and tie their hands. And yet we try to give them within a phase wiggle room to meet the needs of their county because every county is not created equal. And vast population differences. We have 17 counties, I think it's or 15, that are high on what's called a social vulnerability index, poverty, racial and ethnic and income discrepancies. So some counties are just at higher risk. We try to take that into consideration as well when it comes to the allocation. So this is it's a equation with many moving parts.
Sure. Let me ask you a question. We actually, it was one of the questions I wanted to ask, and we did get a chat on this. We are the Olathe Chamber of Commerce, and most of our listeners are businesses. When do you expect to enter into a phase where you will be going out and meeting with HR professionals and actually, distributing vaccines through maybe at a business site or working with businesses in that regard? And I assume that's probably more the general population. That's probably a later phase. But when do you anticipate that happening? I know in some other states, and this may be happening where with companies that are frontline or others like meatpacking plants and things like that, where you're going on the site. But when do you anticipate, Dr. Norman or Dr. Ariel, actually coming into businesses and working with them?
Well, I would tell you that in Johnson County, we have been doing that. Again, the health department cannot be the only channel through which vaccination is occurring. That's just not going to be an efficient system. And that's why our plan from the start was not meant to depend on us running 2 or 3 clinic locations. That's why we are going through establishments that people in the community already have relationship with, because that's a big part of it. So we are, in some cases, having to take vaccines to organizations, but because of this partnership, we have several pharmacy organizations that are taking that on. I talked about IDD Group, Intellectual and Developmental Disability. We had a third-party pharmacy that took that on. There's a large employer in the county here that reached out to us several weeks ago, and they know that they're in phase 2, tier 3, because we broke our phase 2 into three tiers. But we've worked out all the logistics that all they were waiting for from us was to provide the vaccine. And now that we provided the vaccine, it's ongoing. And I'll make an announcement now today here so that it's clear. We're going to be reaching out to all of our chambers, including yours, team, and our clinics next week are targeted towards grocery store workers, as well as restaurants and bars, and other essential workers. And in some cases, several industries already have a list of their employees, and we can work with that. In many cases, they have had the employees go and complete our online interest form, so that we can invite them to book an appointment for the clinic. So this is going on in multiple ways. We have Olathe Health that's working with Salvation Army to vaccinate in a specific group. We have Advent that's now going to, apart from the 65 plus, that's going to be focusing on vaccinating the grocery worker categories. So really, it's been a very broad approach. Some will come to our clinics, others will make a different arrangement for. And so it's easier to answer if it's specific, but all of those have been going on simultaneously, and I expect those to continue. I would say lastly that the difference, though, I find that our flow, our logistics is getting easier when we're vaccinating in the 80 plus residents, and the weather was pretty harsh. By the way, the week of the harsh weather, Dr. Norman, we were vaccinating. We canceled one day, but we were vaccinating. Our residents were careful. We had 3 different clinics that week that we gave out close to 5,000 shots that week. And so in the county, so we didn't have at the Department of Health and Environment clinic, our partners gave out even more that week. So anyway, to answer your question more specifically, if there are people that have specific questions about a specific industry, you can just email us, jcdhe@jocogov.org, or call us 913-715-2819, and we can make that happen. I would say that I don't think we have the resources for a department of 145 staff to have staff that's going to go to every location, but we do have a partnership. We have some pharmacy partners with multiple mobile units. That's what we're doing with our long-term care facilities that are able to deploy to different locations and vaccinate. So there are options that we can work out, but we can get into some specifics if you want through personal communications and conversations.
Thank you, Dr. Ariel. Dr. Norman, I'm going to jump to another question that has come up, if that's okay. I think, there's been a number of different strains that have been, announced, and how comfortable are you with, and I'm going to actually combine two questions if possible. These different strains, the current vaccines, how comfortable are you with them, addressing those strains? And then the other, maybe, and you can jump into the second half, is once you've been vaccinated, and there's a lot of questions that we've asked, how should you interact with people? Should you continue to wear a mask? What can and can't you do once you've at least had the first vaccine? And so can you address those two issues, the variants, and then what can you and can't you do with once you've been vaccinated at least once? The reason I apologize, there's some great questions and we're running out of time. I think we could go 2 hours with this. So
2 hours at least. Yeah, let me take a whack at it. First off, this COVID-19 coronavirus is doing what viruses do, and that is it's changing over time. And there's many different varieties. We do a lot of what's called whole genomic sequencing. We do it in certain circumstances. If an outbreak is acting differently, we'll do the genomic sequencing to see if it's one of those variants or not. We also do surveillance, both in the samples that come to us through nasopharyngeal or other kinds of samples. And we also do wastewater testing for the various strains. And we have it out there. The only one we have in Kansas right now is that we know about anyway, is the B117 United Kingdom variant. And we know that Colorado has a few cases of the Brazil variant. I think eventually all three of those, I don't know if the South African one will make much of a toehold here, but eventually they will become more prolific, I think, throughout the United States. The vaccines, I don't think anybody has the bottom line on that. We do know that the three vaccines will be protective to some degree or another from not only the wild type, the normal COVID-19, but will have some degree of protective nature against those variants. So go ahead and get the vaccine. In answer to your question about the what can you do and what you can't do, the CDC issued some kind of slightly unclear guidance. I'd be curious what Dr. Ariola says, but they really only, what can you do once you have once you are fully vaccinated? And that's a term, you're not fully vaccinated after one of the Pfizer's or Moderna's. It's 2 weeks after you've received the second dose of that you are considered fully vaccinated. Similarly, 2 weeks after the one Johnson & Johnson, you're fully vaccinated. What the CDC has said is they've given guidance for private and home settings that they are not included. They're not saying it about business or work settings. And what they're saying is if you're in your family members and you're fully vaccinated, you can take your masks off and kind of be a little bit more towards normal. You can have another family over if they're and vaccinated also, but still be a little bit of caution. Sanmi, do you think I said that right? But when it comes to implying that that's at the work setting, as a matter of fact, we had a big powwow about this today right here in my own agency. We're all fully vaccinated in our incident command, where we've been for 413 days, I might add, and we leave our masks on and socially distanced still, and we're fully vaccinated. So I did not want to think people that are fully vaccinated can feel they can decrease their amount of protection now. I think it will come, but it's not there yet.
Yeah, it is not there yet, and I think you put that very well. It's not for business setting. The guidance are pretty clear. If you have two families, for example, interacting, two, not several, not large gatherings, and they're all vaccinated, you can be there without mask. But if one is vaccinated and one is unvaccinated, the one that's unvaccinated has to be said low risk. And that means low risk for us based on our data means younger people. It means people without any of the predisposing factors or comorbid factors. So those are very, very limited exceptions. I think in a way it does give additional support for premise for why you should get vaccinated, but it's not where I think we've made some gains, but it will be very sad to lose those gains by prematurely taking the gloves off or doing the right things at the wrong time. We have not vaccinated enough persons in our population. The progress are great, but we have to continue to do what we are doing. It does not take much for this trajectory to change, including whether a more infectious virus takes root, or even if it's the same one that we have. We know the things that the virus like. It likes the indoor environment, it likes people gathering together. Now, I do think the next few months is our friend. The weather is better. We can use the outdoor environment more. We can play more. We can increase ventilation, and we should do that. But we're not even close to being out of the woods yet.
Can I ask? Can I jump on that? When do you anticipate that we would reach herd immunity? And when? And I know that has a lot to do with the vaccines. But if you had to guess, when? Well, I guess when would we reach herd immunity or herd? I'm having a struggle with herd. But and then I guess what percentage do we need to reach? And then when do you anticipate or think that we would be there with herd immunity?
I can try and start. I think there are so many variables there. Not the least of which is after this. Like you rightly said, there are at least three groups of people that are people like us who will take the vaccine immediately. There are some that wants to see what happens with even though several millions of us have taken the vaccines across the country and across the world. But you can see, even in phase 1, that some people are just gradually changing their minds and now taking the vaccine. And there's a third group that probably will never take it, and they express that as such. And so that makes it very difficult to predict. And so even you listen to people that do the modeling and those things, it's consistently been a fairly wide range. Of course, there's no question about it. If we can get 80, 85, 90% of our population vaccinated, that's the dream place that we want to be, to get us to not just contain the spread, but to really keep it down, to keep it suppressed. And so the higher that is, the better. Now, vaccination is a tool, and that's why physical distancing continues to be important. Wearing masks continues to be important, and avoiding large crowds continue to be important. And when you add the variable of what's going on in other parts of the world, so the level of vaccination in other parts of the world is also very important, because we travel a lot. We bring viruses in, and we take some from here to other places too. So even if the United States has a higher level of vaccination and other parts of the world are not as vaccinated, that's going to impact where we are. And so that's why it's pretty tough to predict. If I was going to err on the side of caution, and I'll say the same thing, the higher the percentage of our residents that are vaccinated, the better for us. Now, the White House is saying that they have, by the end of May, I think, Dr. Norman, they will have procured enough vaccine for every American. So I would say that for everyone that wants to be vaccinated, that's a good thing. We're probably going to get to a place where our work will change from vaccinating those who needs to educating people and encouraging more people to get vaccinated. I hope that comes, depending on supply, in the next few months. Where we get to supply is not the issue, it's educating the public. And if we're able to get there and get a higher percentage of our population, I think the predictions would be easier to make then. I would still say that rollback has to be gradual, has to be intentional. We have to be careful.
So, Dr. Ariola, from what I just heard, it sounds like we need to get to 75, 80% of the population vaccinated. And you think that based on what the federal government is saying, that might happen end of May, June, before those, is that correct? I mean, the vaccines, or, I mean, it all has to do with vaccines and the amount of vaccines that we receive, I would assume.
Yes, I would let Dr. Norman kind of help rephrase that. I'm saying that the higher the percentage vaccinated, the better. And
sure.
So we also know that people that are infected have some level of natural immunity, which Dr. Norman, I believe, said that you've consistently seen slightly over 20% in the state based on analysis of antibodies in the blood. Is that accurate? So, yeah, go ahead.
Yeah, we've been watching what the American Red Cross has said about donated blood, and about 20% of people in Kansas. We only have recorded 10% of Kansans, according to the testing, have had the virus and should have some degree of immunity. But 20%, curiously, of blood donors have demonstrated antibodies, and that was before the vaccine took place. So I think, Tim, I don't know, I don't have a crystal ball. I would hope that by autumn that we would have 85%, maybe 90% that have either naturally acquired immunity or a vaccine acquired immunity. I wouldn't be surprised to see if we, as early as this fall, would start looking again at boosters. It may be even in the wintertime, but I think our future will be a little bit like influenza vaccines, that we get a booster every year. And I'm hoping that we'll continue with this conversation, and as we develop the vaccine further, it just becomes part of our rhythm. And I think, quite honestly, I think we're going to have somewhat of a constrained springtime, kind of like what we're doing right now. And I think we're going to have an amazing summer. And I don't think it's going to be normal. And we're going to have to do the things that our public health officials talk about with, I think there'll still be some degree of mask wearing and distancing, but I think we're going to feel a lot different as a population, certainly different than last summer. I think we're going to have a lot more happiness and ability to get out and about.
Well, gentlemen, thank you very, very much. As I said, I think we could have gone on for another hour. We're actually past the hour that we had scheduled. So I just want to say thank you both for this information, and anyone that's listening. And we do record this. We will post this on our website. So you can definitely go back and listen to this as well. And both of you, thank you very, very much. And once again, I'd like to thank our sponsors, which are Humana, Johnson County Community College, John Deere, and Nabholz. So, gentlemen, thank you. And hopefully we get through this, and hopefully we don't have to have this discussion again. But I really appreciate this, and this helps our businesses. So thank you very much.
Very good. Thank you. Thank you, Sammy. Good to see you.
Good to see you, Lee. Thank you, everyone.
Thank you. Have a great day.
Thanks.